Okay, people will start joining us as we progress, I'm guessing, but we're going to get started anyway because I want to make sure there's enough time for questions and for comments afterwards. My name is Debbie Picker, and I'm from the Down Syndrome Association of Northeast Ohio. And today's webinar is about Down syndrome regression disorder. And the whole topic started because we were having conversations about the new research out there, and I found it so relevant to my own life story. I have two kids with Down syndrome, and my younger one was adopted when she was about 2 years old. And about the age of 14, she started acting differently. She stopped talking. She started moving incredibly slower. She ate slower. She walked slower. She lost all of her affect. That means she was not animated like she was. She was part of our family of 6 kids, and there was always something funny or silly or dramatic going on. And she lost her ability to laugh at things. She just had no reactions. She stopped talking, as I said. She stopped initiating interactions with other people. And a lot of her behaviors became very stereotypical, like, waving things in front of her face or playing with the same scripts, which she had done all her life, but now it was far more significant. And she was lethargic. It was really hard to get her up and moving. So because she was 14, I wasn't sure if that was, oh, she's going through puberty. So some of the characteristics of autism she had, I thought maybe were becoming more significant. Or at 14, she started having seizures. So I thought maybe it's brain damage from the seizures or a reaction to her seizure medication. I wasn't sure what it was. And the fact that she had been adopted and she had been abandoned for 2 years before we adopted her, I also thought maybe it was some kind of attachment disorder. So I took her to be assessed when she was 14, and they diagnosed both with bipolar disorder and autism. So autism I could buy. Bipolar disorder, I wasn't having that one. It just didn't make any sense to me. And all now that she's 36 years old, we are seeing that she still has a lot of these characteristics, and a lot of those characteristics were due to the reasons that I gave, but not all of them, because sometimes you have a combination of reasons for behavior. This was not, these factors were not the cause of her sudden and significant regression. So, but without a formal diagnosis of Down syndrome regression disorder, we don't actually know for sure whether that's what it is. Pardon me? Whether that's what it was or not. But with the recent studies being done, this is a strong possibility. So tonight, Dr. Laura Cifra-Bean is going to review all the current information about Down syndrome regression disorder and talk about it from the perspective she has as a pediatrician, as the medical outreach director of DSANIO, the Down Syndrome Association of Northeast Ohio. And she's also the parent of 3 adult children, one of whom, Chris, also has Down syndrome. So she's very knowledgeable on all of these topics. She's currently making a lot of the doctors and medical professionals in our area aware of Down syndrome regression disorder, and she's helping to push for more accurate treatments or more targeted treatments toward helping this. She's making medical professionals aware of the impact on the families and the importance of the treatments. So what we're going to do, how we're going to do this is we are going to mute for now. And if you want to turn off your videos, you can. But we really encourage you to share your stories when we finish. Share your stories and ask any questions that you have, because we'd love to hear from you what your experiences have been. And Dr. Laura Cifra-Bean, you want to take it away?
Thank you. Thank you for having me here today. I'm gonna start sharing my screen. Trying to move this. Okay. So as Debbie said, we're here to talk about Down syndrome regression disorder. This is a relatively new title. There's been various ways that it's been described over the years, from obsessional slowness, Down syndrome disintegration disorder, unexplained regression in Down syndrome. But in the last couple years, an expert panel came together and through consensus settled on Down syndrome regression disorder, or DSRD. So that's what we're here to talk about tonight. Just a little disclaimer that Disanio is providing this for information only. By accessing this webinar or our website or talking to any of our staff or volunteers, we are not giving specific medical or legal advice, and this does not constitute any type of professional relationship. To get specific advice on your family or your child, you would want to talk to your doctor or your attorney or your professional in terms of any information Disanio dispenses. Okay. So we're here to talk about regression, and regression is a loss of skills, and this can happen at various times throughout the lifetime of a person with Down syndrome. And there's many causes of regression. DSRD is by far not the only cause of regression, so you really need to have a thorough evaluation to decide what is going on. But at different life phases, there might be a diagnosis that it comes into what we call the differential diagnosis, which is the list of things we think about as causing a specific set of symptoms. If it's a young child, then with regression, we would think about autism maybe. In a teenager or young adult, then we would think about Down syndrome regression disorder, which we'll talk about as DSRD throughout the rest of this webinar. And in a person aged 40 or older, then maybe you would start to think about Alzheimer's. That's an important point. It's very rare to diagnose Alzheimer's in a person with Down syndrome before age 40. So if somebody's trying to say that a person who's 25 has Alzheimer's, that doesn't fit with the most common thinking about when Alzheimer's happens in people with Down syndrome. So Down syndrome regression disorder is the acute onset of neurologic or psychiatric symptoms in a typically healthy person with Down syndrome. And this usually happens, it's noticed rather acutely over about weeks to months. And this again would distinguish it from more like an Alzheimer's thing at an older age, which is like a slow decline. This is somebody who's doing their stuff, going to school or doing whatever their activities, and then there's a change that's noticed over months. It usually occurs in a person who's between the ages of 10 and 30, and often in teenagers, like 14, 17, it happens often. If everybody could mute, we're hearing somebody. Thank you. And DSRD is diagnosed only if no other cause of regression can be found after an extensive medical evaluation. Okay, so the symptoms of DSRD can be altered mental status or behavior, such as increased or decreased appetite, like eating very little or very slowly. People can be confused or disoriented, but not really know what's going on or where they are, and can just have some inappropriate emotions like laughing or crying when that's not really what would be appropriate at the time. There can be symptoms of cognitive decline, as Debbie was talking about, apathy, like just not really interested in what's going on or in their normal activities, and getting activities finished or started, it just really loss of momentum, loss of motivation. and also some memory problems. There can be developmental regression where people really withdraw from their family and their friends, and they just want to stay in their room. Now, I know a lot of people with Down syndrome, including my son, like to stay in their room a lot. But this is when we talk about these things as symptoms, it's where it's out of normal. It's interfering with daily activities. Like you can't get your life done because somebody won't come out of their room. There can be loss of skills or milestones and the inability to perform activities of daily living. Like if they used to be able to get dressed or shower or, make their toast or whatever, now they can't do that. The repetitive hand or body movements that Debbie was talking about, we call that stereotypy. And they're meaningless, they're motionless, but there's just movement. And difficulty changing routines, which again, I know a lot of people with Down syndrome like their routines, but this would be out of the norm. And you really an increase in just not wanting to change. There can be a new onset of seizures or neurologic problems, and there can be lack of sleeping or a big change in the sleeping pattern where they're sleeping late and then staying up all night. And a big thing is loss of language skills, where they're not talking as much or they're talking baby talk, whispering instead of talking, or just not talking at all. And also difficulty comprehending language or understanding words. Movements can become difficult. There can be freezing or slowing, and that's called bradykinesia. I'm saying these specific words because there's articles that I'm going to reference later that you might want to download and take to your child's doctor with you. And I want to make sure these are the words that were used in the article. So I want to make sure you know what they mean. So bradykinesia is like very slow movement. Catatonia is a total lack of like reaction to the environment. And it can also include like getting stuck. I've heard of people getting stuck like halfway up the stairs and they're just frozen. They don't move and they're like stuck in a position. And it's even difficult for somebody to move their leg or unbend their arm. And that could be catatonia. Just repetitive random movements can occur. And then there can be cataplexy, which is the sudden loss of muscle tone. Like they might drop to the floor or their head might drop and they were there and then they're not. So that's another movement disorder. Oops, sorry. There can be psychiatric symptoms such as anxiety or depression. Now, this doesn't mean every person with Down syndrome who has anxiety or depression has DSRD, because that a lot of people with Down syndrome have anxiety and depression, and it's not necessarily regression, but that can be one of the symptoms. Hallucinations, like seeing or hearing things that are not there, or delusions, believing things that are not true. Sometimes it's that the self-talk changes. I mean, many people with Down syndrome do self-talk, a lot of self-talk, and can have imaginary friends or imaginary people they talk to. And, if things sound positive and it's not interfering with anything and they kind of know they're imaginary and they can come out back into the real world and interact and do their stuff, then, we don't really worry about that so much. But if it's getting to the point where like they think voices are saying mean things to them, or they're kind of stuck in the world and they cannot tell that it's imaginary and they're like kind of caught up in it and they can't make it go away and it's bothering them, then that's when it's a problem. There can be obsessions or compulsions, which again, a lot of people with Down syndrome are like pretty stuck in their routine and have things the way they want to do it, and you don't want to change that. But this is when it interferes with daily activities. So for the workup, it's important to remember DSRD is what we call a diagnosis of exclusion, which means we rule everything else out that we can to try to see if there's another cause of regression, because we want to know what's causing the regression and we want to treat the appropriate thing. And if nothing is found and you fit certain criteria, then you would think about DSRD. To do this, it's very important to have a provider who knows about Down syndrome and knows about DSRD. And the evaluation can involve multiple specialties. It can be a Down syndrome clinic, it can be a neurologist, it can be a psychiatrist, it can be a neuroimmunologist, an immunologist. So there's many different people that can be involved depending on the symptoms and what's available at the center you're going to. So Dr. Jonathan Santoro, he was the first author on this paper that came out in 2022, which really brought together a lot of the information that I'm going to go over in the rest of the workshop. And he's a neuroimmunologist from California who for some reason saw a person with DSRD, and to him, it seemed like it was very similar to what he had been treating patients without Down syndrome for, an autoimmune encephalitis. So autoimmune means the body is making antibodies or causing immune reactions to attack the body parts itself, where usually our immune system is to fight off things that come from us from outside the body, like viruses and bacteria and things. But sometimes our bodies make antibodies against our own bodily tissue, and it can cause problems. So he started treating people with IVIG, and we'll get into that later, and having some success. And he's really been a spur to get the expert consensus on the assessment, the diagnosis, the workup, and the treatment. So this paper is excellent. It can be found at the link on the slide, and also the QR code. Can you guys see the QR codes? Yes.
Yes.
Yes, thank you, Melissa.
Yes.
So for the QR code, I'm sure you guys know, but point your camera at it. A little yellow rectangle will come up, and if you press on the yellow rectangle, it will take you to that paper, and then you can download it on your phone or text it to yourself, or however you keep track of your documents. But throughout the webinar, there will be QR codes that you can look at with your camera and download to your phone or iPad so that you have a copy of them. So anybody who is concerned that their person or somebody they know might have regression, I highly recommend this article. So the workup they recommend starts with a brain MRI. There are some findings on MRI that can be suggestive of DSRD, but I've heard Dr. Santoro talk and say that they've also found unexpected things like evidence of strokes and things like that on the MRI. So it's important to get imaging. Blood tests, there can be many blood tests. A blood count, there can be other blood tests that are signs of inflammation. A lot of the blood tests have to do with looking for those autoantibodies. The thyroid, the TSH, the thyroglobulin, the thyroid hormone receptor antibodies. A lot of people with Down syndrome have thyroid disease that is autoimmune, and the antibodies that attack the thyroid and then lead people to need to be on Synthroid because they have hypothyroidism can start to attack other parts of the body. Also, celiac disease is an autoimmune disease, and it's important to look for that. Celiac itself can cause behavior issues, so that's important to know whether somebody has celiac disease. Then the cell-based autoimmune encephalitis panel is looking for antibodies that may be attacking the nervous system that could be a cause of regression. They do suggest a lumbar puncture, a spinal tap, which a very small hollow needle is inserted between the vertebrae into the area around the spinal cord to get out some spinal fluid that they test to make sure there's no signs of infection, but also to test for any signs of inflammation and that there is some autoimmune encephalitis going on. Then there are a large number of tests that are listed as clinically indicated. So depending on the person's symptoms, there are many, many different tests to choose from that one might, that a doctor might choose to order on a patient. Very commonly, one might do an EEG to make sure it is not a seizure disorder, or if there's any evidence of seizures, a sleep study for obstructive sleep apnea that can cause a lot of change in skills. And then it's always important to keep track of hearing and vision, because changes in either of those can lead to loss of skills and also can contribute to like cognitive decline with dementia also. So all people with Down syndrome, we want to keep track of their hearing and vision. And then, once once the workup is done, the treatment will depend on what is found during the evaluation. If they find something treatable, then, referral to the appropriate specialist or treatment will be undertaken. If no cause is found, then the diagnosis of DSRD would be considered. So Dr. Santoro has another article out along with doctors from Pittsburgh and Boston Children's that go through the therapeutic advances that have happened over time in treatment of DSRD. And these links and the QR code it won't take you right to the paper, but it will take you to a page where you can request a copy of the paper from the authors, and I highly suggest getting a copy of this paper also. So there's been multiple categories of medicines tried over time. Historically, DSRD has been thought to be a psychiatric disease because of the behavior changes. So since my career has started, and I've been a pediatrician for 30 years, everything until like the last 5 years has been treating it as a psychiatric disease. So many different psych meds have been tried, antidepressants, benzodiazepines, such as Ativan, because that is one of the primary treatments for catatonia in the general population. So that's been tried a lot. Antipsychotics, because of the delusions and hallucinations, have been tried. Electric convulsive therapy, as many people with DSRD have been treated with this over the decades. And for ECT, electric convulsive therapy, it is done under general anesthesia, and there are electrodes that they put on the outside of the skull that give an electrical current that does cause a seizure in the brain. And for reasons that nobody really has known over time, somehow that changes the chemicals in the brain and has been found to help with different forms of mental health conditions. So if you would like to know more about that, there's a good resource from the Mayo Clinic that will tell you more about ECT, just keeping in mind it does involve general anesthesia. Then in the last several years, different immunotherapy has been tried. Dr. Santoro is he's the one who's doing a lot of IVIG, and that's intravenous immune globulin. So that is, people donate blood, and their blood is pooled and separated, and the antibodies from that blood is concentrated into a liquid, and then that liquid is infused intravenously over several hours at certain intervals, and it damps down the immune system to help fight that inflammation. Then there are Janus kinase inhibitors that are also work to dampen the immune system, and you might see the commercials for like Xeljanz and things like that for rheumatoid arthritis, psoriasis, ulcerative colitis, and those have been tried. And then steroids like prednisone, things like that, which have effects on the immune system. If you want to find out more about IVIG, you can go to the top QR code, and to find out more about JAK inhibitors, you could look at the bottom QR code. And then this is from the Santoro article, going over the different treatment options. It's a little bit of a busy table, so we're just going to focus on this effectiveness right here, and then the all patients, which is the column at first, the first column with the N equals 48. So you can see um, antidepressants were 48% effective, were effective in 48% of the people. Antipsychotics were effective in 64% of the people. Benzodiazepines were effective in 76% of the people. ECT was effective in 78% of the people, and IVIG was effective in 89% of the people. And, if you look across the table, the IVIG was effective whether or not there was really signs of inflammation in the spinal fluid. So even if they didn't find signs of inflammation, the IVIG was still helpful. So luckily, there is more studies being done about the different treatment options and their effectiveness and safety. And Jonathan Santoro, along with doctors from Global Down Syndrome Foundation, Dr. Espinoza, who is a big researcher in the immune system and Down syndrome, are currently enrolling patients for a study. You can get to the study page through the link or through the QR code if you wanted to find out more about it. And it's comparing lorazepam, which is Ativan, against IVIG, against the tocilizumab, which is the Xeljanz. So, and from what I hear, they are going to try to help people after the study get treatment if it's found that something is effective for the people participating in the study. Just some more resources for you. Down syndrome, the top resource is from Down Syndrome Medical Interest Group. That's a group of like doctors, nurses, therapists, professionals who are interested in caring for people with Down syndrome. And they have a very nice handout on regression that you can find at that link and QR code. And then Down Syndrome Resource Foundation is out of Canada. And they have a wonderful podcast called the Low Down Podcast that covers a variety of topics. I've listened to a lot of them. They're really helpful. They're really good. But they have one specifically on DSRD, and Dr. Santoro is in it, and Dr. Eileen Quinn, who's a developmental pediatrician from Toledo, whose daughter who has Down syndrome went through regression, is also featured in it. And then Dr. Quinn also runs a private Facebook group for families whose members are having regression, and I'm a member of the Facebook group. My son does not have regression, but in my role as medical outreach director, I was allowed to join the group, and it is full of helpful information. People post very specific things like what medicines their children tried, what doctors they're seeing, how they got insurance coverage for things. And many, many people in that group have had their child see Dr. Santoro, and they just really say a lot of good things about him. So in terms of what resources we have near us, the Cleveland Clinic, Dr. Mary Wong runs their Down syndrome center, and I've communicated with her recently, and they have evaluated a couple people for DSRD. I know in Pittsburgh, Dr. Kishore Valodi runs their Down syndrome clinic, and they do have a protocol for evaluating and treating DSRD, as does Cincinnati and Columbus at Nationwide Children's. So, and then for University Hospitals of Cleveland, for adults, Dr. Thomas Scheidemantel is a psychiatrist with a special interest in treating people with intellectual and developmental disabilities and an interest in DSRD. So he said I could share his contact information today. UH does not have it totally set up to do the whole evaluation and treatment, but they are working on it, as Cleveland Clinic Children's seems to be in the starting process of it. And then very fortuitously, Dr. Santoro is doing a webinar with National Down Syndrome Society on September 19th at 7 p.m. So if you click on that QR code, that will take you right to the Zoom registration to register for that. I'm definitely going to that. And then another program we're doing for all of us parents who might be a little stressed is with Soulbird Consulting, Soothing Anxiety Through Trauma Sensitive Mindfulness. And they conducted a series of classes through Ohio Department of Developmental Disabilities in the last year. And I attended the whole series of classes and I found it very helpful. So then Debbie and I were talking, and Debbie reached out to them, and they're going to do 3 sessions for us, broken up by age group 0 to 5 um, on September 18th, parents of children ages 6 to 21 on September 25th, and October 2nd for parents of adults. And if you would like to find out information about that, you can RSVP to Debbie. Okay. If you have questions after this, of course, we're gonna stop recording and have our discussion, but also you can always reach out to myself or Debbie. DeSanio is happy to always try to help our families however we can. Thank you.
Thanks so much. That was very, very informative. And